Thank you so much. So up next we have Dr. Sujatha Mohan, a very senior and experienced cornea refractive cataract surgeon who will be talking to us about management of flap mishaps.
Thank you, Shreyas, and I'd like to thank Geetansha for giving me this opportunity once again. So when I spoke to her, she said you can talk on anything. So I decided to go for we have nice videos on flap striae management. So the flap striae can be broadly divided into micro and macro striae, and they can occur because of various causes. It can be just replacing the flap improperly, or it could be a contraction or desiccation of the flap wrinkling, movement of the flap, or rubbing of the flap. Or we commonly see it more in a nasal versus a superior range, and excessive manipulation. So this case, you can see the striae in the center. The other eye had 6/5 vision, and this patient was able to recognize there was something wrong with his eye, and she had only 6/9. And you can see that I have dilated the pupil. It's best to dilate the pupil because you get good retroillumination, and the striae are mostly in the center. And it's just 1 day old, so there's a simple stretching technique. Just do a perpendicular stretch, use a stiff Merosil sponge, and then float the flap into position. Don't worry about a little bit of epithelial defect that you might create, and mainly concentrate on the center area because it's not possible to remove all the striae, but just give whatever is the best. And once you have done this, you can put a bandage contact lens so that the patient is more comfortable, and then you get a very good effect. You can see that the post-op, the first day itself, you can see the striae is reduced significantly, and the patient was 6/6, and then overall we went on to get back a 6/5. So this is again a patient who had a trauma on the third day, or he just rubbed his eyes, and you can see that the flap is shifted out of position, and it's all because he had gone away. It took him a couple of days to come, and by the time the epithelium had grown over the exposed stroma. So this is a tricky situation because if you just leave it like that, the patient is going to have an epithelial ingrowth. So it's important that we remove, even before we lift the flap, we remove all the epithelial remnants over the stroma which is exposed. And not only that, because the flap is twisted out, the striae are quite dense. And you can see that once I have completely removed it, I have also made a 2 millimeter area of epithelial removal around the margin of the flap. This is to prevent epithelial ingrowth. Now you float the flap into position. You can see that a thick striae, and these striae, the epithelium grows into the striae. So it's important that we remove the epithelium to get the best effect. And so almost 360 degrees removal of striae was done, of the epithelium was done. So, and after that, my technique is only just stretch perpendicularly. You can use, there are various techniques described in literature where you can do ironing, and a simple just using a muzzle hook, wetting it in warm water, and then ironing, not using too much of heat has seemed to help in certain cases, but this seems to work for me. I'm just stretching perpendicularly. Just make sure that you float the flap into position. And because I knew this was a very thin flap, I decided to suture this flap. Normally, you really need not do it. I'm using 11-0 nylon sutures in this, and 1-10-0 nylon. It's while suturing, you have to be very careful not to shift the flap, and then applied a bandage contact lens. So this is a post-operative visit, maybe after a week or so. You can see that 10-0 nylon suture still visible. And this patient has almost a 15-year-old follow-up, and I really can't make out which eye had done this procedure. So this is again another patient who had a flap striae. You can see these are quite dense striae, and the epithelium is also disturbed a lot. So again, removing all the epithelium from the base of the striae. And see, in this case, you can see the striae better because I've dilated the pupil. It always helps to dilate the pupil. So you can see the striae better, and they are quite dense striae. The flap is very thin. So if this doesn't work, sometimes you might have to amputate the flap. But in this case, we just went ahead with the stretching technique and sutured the flap, and we had pretty good results. So this was again a traumatic dislocation. You can see that the whole flap is lying on the conjunctiva. So again, meticulous removal of all the epithelium. The flap is scrolled because of the epithelial ingrowth. Again, take care to completely scrape off all the epithelium. You cannot physically see it or clinically see it, but you have to take as much of care as possible to remove all the epithelium. Wash out nicely. And you can use absolute alcohol. That's what I've been doing recently. In this case, I've not used anything. And again, sutured the flap after removing about 2 millimeters of the epithelium all round. This is again a traumatic dislocation, and so again meticulous removal of the epithelium. So the main problem here is not the flap, it's the epithelial ingrowth the patient is going to have after you have put the flap back, and that is going to be a big bugbear to treat. So see here, you can see I'm using absolute alcohol, a 20% alcohol, which we use for devitalizing and using for LASIK. The same thing you can apply on the bed. So what happens is, at least whatever epithelium is remaining behind, which we are not able to see, at least it will not multiply. So that's the idea behind it, because it devitalizes the epithelium, and then only risk is that unless you wash it properly, you can have pretty significant DLK. So the pearls are early intervention, care to avoid epithelial ingrowth, apply a suture if necessary, bandage contact lens. And in late striae, you can use hyperthermic ironing using heated spatulas. And in patients with very severe striae not responding to conventional treatment, you can do a PTK. Okay, I think I'll just stop with this.
Thank you, madam. Very, very interesting videos. As a small caveat, what would you say if, I mean, those large macro striae, of course, we'll have to remove the epithelium. But micro striae, where patient is presenting a little late, a month later, when they come for a post-op, little vision is defective, 6/9 BCVA. When would you recommend epithelial removal for those type of striae, because they are presenting a little late? Would you do it, or would you still just stretch?
Yeah, I would do it, because I think if they're going to, the rest of their lives, they can't be living with a compromised vision. So if it is in the visual axis and it's compromising the vision, whatever time they're present, we'll have to lift the flap and remove the, definitely epithelial removal. The later the striae they're present, then you really need to remove the epithelium. If there's a striae is in the periphery, then probably you should look for other causes for patient's discontentment. But otherwise, if you can see a clear striae in the center, you must go ahead and do it.
So would it be safe to say that unless it's immediate post-op, whenever the patient presents a little later, you would think of removing epithelium?
Definitely, yes. Thank you. There are striae which are just Bowman's breaks, which you really need not do anything about. But if you see clear radiating striae coming from the hinge, which is the typical description of a striae, then it's better to intervene. Because over a period of time, the patient will start recognizing the difference between one eye to another, and the abrasions will be definitely much better, much worse in the eye which the patient's having striae. So, but it again depends. It's a very, very small, fine striae. It's because of Bowman's breaks. You just leave it alone. But if you see the typical ones which are radiating from the hinge, I think it's better to go in. I would. Yeah.
Sorry, Tanvi, just once again. No, we can continue. If I'll request Dr. Ramurthy just set up his laptop while we can discuss it.
Do you use distilled water while you're before removing the?
No, I'm not. I know there are a lot of reports just using distilled water. I don't. I use just regular BSS. Yeah. Only thing is, I would like to dilate the patient, because then it gives us a good glow about glow.
Is there any role of doing it faster, because the more you're handling the flap, it becomes more edematous and towards the...
It doesn't matter, because I think the handling the flap faster comes only we are going to do a laser ablation, because you don't want to dry the bed. It doesn't matter. You can take your own sweet time, and of course we are going to do it under topical anesthesia. Maybe patient is anxious, you can give him medoxylum, but you can do it. Take your own time.
In fact, you need to give the ironing a fair bit of time. It is not an instant fix. And we use hypertonic solutions. So you mix BSS, and because if you swell up the flap, it's after removing the epithelium, we swell up the flap with hypertonic solutions. If you're using just pure distilled water, it does become more edematous, and then the apposition may be a problem. So we use a 1:1 mixture and continue the ironing for a fair bit.
Also, the challenge is that the striae don't really completely disappear on table, and it's only the next day that they look clearer. So there is no defined or definitive endpoint. So taking some time to ensure sufficient ironing has been done, and that sufficient is how much is sufficient is obviously, I think, case dependent. So thank you so much.